Hi, YouTube. Say hi, Natalie. Look at them. They're right over there. There you go. You can wave too. Say hi. So we're doing thoracic HVLA. There's three main techniques we're going to review. There's the Kirksville crunch, also known as supine thoracic HVLA. There's thoracic prone HVLA or Texas twist. And then there's the full Nelson HVLA. So these all have really fun names, but we'll go over each technique here. So let's find any thoracic dysfunction going on. Do you have any pain? Yeah, where? Whole thing? Okay. Kind of goes all the way down. So rotated right, side bent left from like T1 to 10. Let's have you lie on your back. I'll show you a quick and easy way that I like to diagnose supine, because a lot of my patients, they just come in and lie on their back. I call it the pizza pan test. So I take, and this isn't Comlex, approved. This is just how I do things clinically, that it can be quick. So I slide each hand underneath the patient, target the thoracic vertebrae, and then I just kind of spring up like this. And I spring and find where there's restriction here. So what I can see is that certainly in the upper thoracics, she's more rotated right, just like I found when she was prone. So we're gonna do thoracic HVLA. So the way I like to remember is you stand on the opposite side of rotation, so I'm on the left side. I like the table height to be, just above my knees, maybe a few inches above, because my xiphoid needs to be over the midline of the table, especially over the area I'm correcting. And then I'll have the patient bring the top, say topposite, so opposite arm is on top, bottom arm, closer arm is below, and you have a V, right? So if you want to come and look kind of at this angle, this creates a V. If the patient is doing that, W for wrong, that's not correct, right? Because this doesn't distribute the force as well through the correction. So here, my force, I'm kind of folding her elbows over, and I'm gonna deliver a force with my xiphoid on top of her elbows right through my thenar eminence. So the way I roll the patient, I have my hand on her shoulder using my elbow as a fulcrum, and I just do that. I see a lot of people using both hands and then rolling the patient too much. It's so much easier just going here, rolling. I'm gonna correct right around T4. So the way I find it is I find the spinous process with, my middle finger here. And then if you match the spine with the center of your hand, your thenar eminence ends up being right on the transverse process, okay? But you gotta keep in mind, if I'm finding it with my middle finger and I'm just doing that, I'm way too low. So once you find the spinous process, bring your thenar up to the level and then line up her spine with the middle of your hand. Then I just roll the patient over. Now the next part is I wanna tuck right here, all right? So I use my other hand, tucking the elbows. I'm putting my xiphoid right on top. And I'm trying to feel pressure down in my thenar eminence, okay? The next step, you can cradle the head and just slightly side bend away from you because it's side bending right and we're rotating left. So that's gonna help. And I'm cradling the head with my hand, and then she takes a deep breath in and exhales, add pressure, and then drop, okay? So you okay? And then let's have you roll face down, and then we reassess, right? So corrected that T4, and she does have a better rotational component. However, she has muscle hypertonicity, so can spend time doing soft tissue, etc. Now the next technique is the Texas twist. So if you want to come really close and see where my hand placement is, you have your hands here, arms straight, and you're leaning right over the segment. Now you want to match your hypothenar and thenar eminence into a line. So it should be like a straight line here, right over the segment. I saw some students doing this. That's not as localized, but you want to go here. So if she's rotated to the right and side bent left, you want to side bend right. So if you look, the fibers of her clothes with this hand placement side bends right. If I want to rotate it left, I just add more pressure with the closer hand here. All right. Now if we side bend left, it's going to look like that, okay? And that's not what we want to do. So we want to side bend right, rotate left, and then I add some pressure. She takes a deep breath in, exhale, straight down, okay? So it's a straight down thrust, a little bit more pressure on the rotational component here, closer to me. We didn't get an articulation, we just already treated it, but that's how you would do the technique. You could also stand on this side, and if it's still rotated right, side bent left, you could just do the increased pressure with this thenar eminence, and it is, there's Dr. Aben eating in the background, you see him? He can't find any peace. Someone said that. They're like, let the man eat. So it's side bent right and then rotated left because you're increasing pressure on this right transverse process. So that's Texas twist. The last one is what we call full Nelson. So you can sit with your legs off the table. And this one, you want the patient to scoot all the way back. So right back against, you don't want their knees to be locked here because that's gonna prevent the technique from, from working correctly. I want to increase the table height so that the crown of her head is just at my nose level. My eyes are kind of right above here, so like this height. First step is you diagnose, right? So this is typically done for upper thoracic vertebrae. All right, and it's honestly, it's a lot better now. Still, there's really minimal right rotation at T1. If I do some springing, she side bends left a lot easier. So first thing I do is have the patient bring your arms out like a T, so arms straight out. I go under, hand here, under, and if you look at my stance, I have a really wide lunge here, and then I lock my fingers like so, all right? And then I make sure my sternum is up against the vertebrae that I'm going to adjust, which is like T1 over T2. And then you lock your fingers behind your head and put them on top of my hands, kind of right there, okay? Now I will just lean slightly back. My vector is kind of up and slightly behind me. And then with, sometimes I'll have the patient just bring your elbows slightly together, there. And then the thrust is take a deep breath in and exhale, and it's straight up, okay? Then you bring your arms down, and then we reassess. Doing okay? And then we check side bending, better side bending right, okay? And then bring your head chin to chest, and then straight up, turn right and left, okay? And then straight ahead. Any pain going on up through here? Cool, so that's the full Nelson technique. That one is not in Nicholas. It's one we teach at Rowan. But you can also, do this for really upper thoracic if you're having difficulties localizing. But let me show you how to localize high thoracic and low thoracic for Kirksville crunch, or the first technique. So lie on your back for us again. It's all about angles and vectors. So if you want to come around to this side, we'll lower this slightly down. So our setup is the same, okay? Now, if I want to go for, let's say, higher, like T1 or 2, you can have the patient bend her knees, feet slightly out, and then here, and then I find that transverse process with my thenar eminence right below it. I wedge her elbows under me, and then I want you to make a bridge with your hips. Yep, perfect. And that increases my localization straight down, okay? And then relax your legs. So that's how you get upper, and we got that correction, which is great. Now we go lower, and you can straighten all the way. Let's say it's like T10. I'm gonna need to change my stance. So if you come to the side of me, if I'm just going for a mid-level, I'm kind of right lateral to her. If I'm going for lower, I gotta slightly change my stance and angle this way. And then I bring her arms into the center line, I'm over it, and then straight down like that. So if it's like mid-thoracic, I'm straight on, boom, upper, change that angle slightly. She has to raise her hips, and that gets the top. And then for the bottom, I have to angle this way and drive there, just so we can make sure that our force is going through the patient right into our thenar eminence. No. So Dr. Bavishi brought up a good point. For type 2, we used to do the whole fuel and fossab, and it was really confusing. If you don't know what that means, it's okay. If it's like a T4 flexed, rotated right, side bend right, same thing, just stand opposite side of rotation and do it just like if it was a type 1 rotated right.